So the diagnosis is widespread pain, 11 of 18 tender points, and the occurrence of comorbidities support the diagnosis, including chronic fatigue syndrome, headache, IBS, cognitive impairment that goes along with chronic fatigue syndrome, and there's no other explanation. And if the diagnosis is not possible, call it chronic widespread pain syndrome. So let's talk about management. So, and I'll just reiterate what I said before. This is really common. This is really, really common. I mean, the observational studies that were population-based suggested that as high as 2% of population meet criteria for fibromyalgia, and chronic widespread pain is more common than that. So this is really very frequent. If you're in private practice and you ask the question, you find many people with chronic widespread pain. And pain specialists tend not to see them that often because they get referred to rheumatologists or to internists. But you know, obviously pain specialists should probably see these patients since it's not a rheumatological disease as far as anybody knows, and general internists aren't really trained to treat it. So how do you manage chronic widespread pain or fibromyalgia? The first step is to determine if there's anything reversible. So back in the 1990s, there was a period of time during which the literature suggested that there was primary fibromyalgia and secondary fibromyalgia. And primary fibromyalgia was fibromyalgia associated with some other disease, like systemic lupus erythematosus, has pain everywhere. They said that was secondary fibromyalgia. Primary fibromyalgia didn't have that. Then in the mid-1990s, a consensus group did away with the primary-secondary distinction, saying that it made no sense, that if a person has chronic pain from some other diagnosis, don't call them fibromyalgia, treat the other diagnosis, and if you can't explain their pain based on the other diagnosis, they have fibromyalgia. So the bottom line is that many different systemic disorders cause pain, and if you can't treat the systemic disorder, you try to treat it, obviously, and patients who can't have the pain reduced substantially by treatment of a systemic disorder, they have chronic widespread pain and they get treated in some other way. So there are many medications that are now available for fibromyalgia. This is actually one of the key drivers also for this view that it's not just a psychiatric syndrome, and that is that there are now randomized controlled trials showing that a whole variety of drugs are useful, and it looks like drugs that are monoaminergic are the most likely agents to provide benefit. So the drugs that have been studied, including in randomized controlled trials, include both amitriptyline and cyclobenzaprine, so Elavil and other TCAs, and cyclobenzaprine is Flexeril, which is also a TCA. You all knew that, right? So Flexeril is just a tricyclic antidepressant that got developed in the United States as a muscle relaxant for reasons that are not clear. But it's a tricyclic drug and has been studied in randomized control fashion for fibromyalgia and found to be beneficial. SSRIs have been studied, both fluoxetine and paroxetine. SNRIs have been studied, particularly duloxetine and also the new one, milnacipran or Savella, randomized controlled trials. So the SSRIs, the SNRIs, the tricyclics, so essentially all the antidepressants have been studied. All the serotonergic and serotonergic noradrenergic antidepressants have been studied for this disorder. In addition, the alpha-2 delta drugs, both gabapentin and pregabalin, have been studied. And you probably see these advertised. This is FDA approved. Duloxetine is FDA approved. Savella is FDA approved. Lyrica is FDA approved for fibromyalgia. Dopamine agonists have also been studied. Again, these are monoaminergic. Not sure whether something specific about dopamine represents an across-the-board pathophysiology or just a subgroup, but a drug like Requip, used for Parkinson's disease, has been studied and is a potentially useful agent for fibromyalgia. More recently, GHP This is Xyrem. Everybody knows Xyrem. It's a hypnotic on the market. It's got a very it's got a quite severe REMS with the FDA because it has an abuse liability. It's known as a date rape drug, and it's a very profound hypnotic. If you ever do prescribe this, and I haven't prescribed it yet, but Dr. Nadelson, for example, has extensive experience. If you ever prescribe this, you have to make sure that the patient is sitting on the bed when they take it, because as soon as they swallow it, they go to sleep. So if you take it standing up, you end up on the floor. So this drug has been used to try to normalize the non-restorative sleep that characterizes chronic widespread pain, and in a randomized trial was shown to be helpful for pain. And opioids have been studied, at least tramadol, and tramadol was positive in a randomized trial. The use of pure mu agonists is controversial. Some of the very well-known investigators who lecture commonly on this say that opioids never work and they're contraindicated. But then if you pin them down and you say, have you ever seen a patient benefit from an opioid? They all have patients like that. So my own view about it is that you probably don't want to promote to primary care that every patient with chronic widespread pain should get first-line consideration of an opioid, because there are these other agents and other categories of drugs that have been shown to be efficacious, and opioids, with the exception of tramadol, are not efficacious in randomized controlled trials because there haven't been any trials. But these drugs can be tried in patients who don't respond or are not candidates for these. So this is, just to give you a sense that we're not talking about one study or two studies. There are actually numerous randomized control trials in fibromyalgia, and they date back to the mid-1980s. You don't have to memorize these numbers except this one. Everybody got that number? We'll go back to it later. Here's another study, just to give you a sense again of the effect size compared to placebo. These are drugs that clearly help some patients. This is Prozac. This is the study that got duloxetine approved by the FDA for fibromyalgia. This is weeks on treatment, pain reduction. This is duloxetine, this is placebo. Notice that in aggregate it takes weeks to get maximum benefit. Right, so I had a patient call me yesterday and say, I had a really bad day yesterday, so I took some duloxetine. I said, throw the duloxetine away. This is Milnacipran or Savella. These are the studies that got this drug approved. This is daily pain diary, weekly pain diary. Milnacipran is the blue line, blue and green line, and yellow line is placebo. This is a study of Lyrica, pregabalin. And again, this is weeks, reduction in pain, placebo response, and response to 3 different doses of pregabalin. There's a suggestion here of a dose response, but not very high.